February task force meeting.
Props
We're going to,
so much. And but yeah, you can't.
all right, there we go. We have four great presenters this morning, so I want to get to that, but I want to cover a couple of things. And the first one of which I think is really very good news. And it is news that really we are only in a place to be talking about because of the continued multidisciplinary collaboration. You guys, people mute themselves. Collaboration that we've had going on. As the members of the task force know, every month I report out our fatal opioid overdose data that we have seen here, the events that our troopers respond to. But since between January, our last January meeting, and February 15th, we experienced 14 non-suicide opioid overdose deaths, and 2 that were clearly people who had died by suicide. And remember, we only classify that when there's no question, when there is a note, when there's been statements, whatever that is. And as everybody knows, any overdose death is too many. But that number reflects a flat 50% reduction since this time last year. Last year, between our January and February meeting, we had experienced 28 deaths and 1 suicide death. So we are at exactly half of both of those numbers, which is very significant. Of course, it then reminds us that there are still people struggling, and so the work can't let up. But when you look at where the numbers have gone in other places, it really is a testament to the way we have tackled this and how we've been able to make a huge difference here. So, and I think that is in part based on what was reflected in our January meeting. You remember in January, we had Cheryl Sabra from the Mass Association of Health Boards. We had John King, the electrician who talked to us about the safe bathroom technology, the detectors. And we also had Dr. Paradise from the Institute for Community Health. And that's really what we've tried to do here. We've tried to look forward, we've tried to be preventative, and we've looked back and reflected on the feedback that we've gotten, particularly those with lived experience, in order to craft going forward. It's been very much a wraparound kind of thing. And, you know, even small things make a difference. And I'll tell you a little bit about something we did last week that we're promoting in our schools. Many of you who've been with us the whole time will remember early on, we did mobile policy forums where we brought together people who had lived experience of addiction to talk about things that had happened that had preceded their beginning the use of substances. And it was really, I think, pretty compelling for everybody when so many people talked about middle school experiences, things that maybe they'd moved in middle school and they never kind of got their balance again. Maybe there'd been a divorce and that had caused going to a different school and all of those kinds of issues. So last Friday was, and I don't expect anyone necessarily knows or observed this, but last Friday was National No One Eats Alone Day. And that's a program that is aimed at schools, particularly at middle schools, and focused on the kids who end up sitting by themselves in the cafeteria, who don't have a group, don't have friends, don't have a place to go. And there is a nonprofit that was begun by parents whose child had experienced some isolation in middle school. And the idea was to encourage kids to think about sitting with other people, bringing people into their group, help them just really think about some of the stuff that even we all struggle with, like what's an icebreaker? How do you talk to people who might not be somebody you've been friends with? How do you open up those conversations? And I had the chance to go to the Coolidge Middle School in Reading and talk about that issue of social isolation and talk with a big group of kids about what they would do, how they would do things, had they ever experienced that. It was actually really compelling. There were 2 children in our group who were fairly new to this country. and who talked about what that was like coming to the school and how much it meant to them when somebody would call them over or sit with them and try to get to know them. Interestingly, there was a child who was from a military family who had moved very often and talked about how hard it was to kind of be the new kid landing in school. And kids talking about how they might have been in that school for a long time, but you know, kids are kids, and at different points, maybe they were the odd man out, and how much it had mattered that somebody would come up to them. Interestingly, one little girl told a story, a pretty compelling story, that she has a very severe peanut allergy. And the way the school dealt with that was she sat alone. And, you know, that was just part of the deal. And she seemed to understand that. But then a couple of girls that she had gotten to be friendly with apparently must have agreed to kind of abide by the rules of whatever they were bringing for lunch so that they were able to sit with her. And she talked about just how different that made her day, having somebody be with her. And the fact that they were kind of willing to alter, you know, getting peanut butter crackers or getting whatever to be able to sit with her. So those are small things, but we know from the work we've been doing that being more connected is a protective factor. So we're really trying to do that. And then the issue is, how do we have those difficult conversations? How do we talk to friends and families and clients about resources and programming? And I really look forward every month to this, to really hearing what you're doing, to talking a little bit about what we're doing. And I remind people who are either our speakers or who might be joining us for the first time, and John Kelly, who's one of our speakers today, I think has been with us since the very first meeting. Back in 2012, when none of us really knew a whole lot about opioids, and we had suddenly seen a just crazily dramatic increase in opioid deaths up in the Merrimack Valley. And we went to a number of stakeholders in the community to ask them if they'd come together so we could educate ourselves and address it. And our plan was that this would be a recognition that this was a community problem. Law enforcement clearly was not going to be able to solve it, and that it was a public health issue. So we seated the task force in the hospital, and then we took that to 5 other hospitals across the county and grew our groups at each of those. And we have met every month since that first meeting in 2012. And over COVID, we kept that going by bringing everybody together. What we've seen is it's given us a lot more flexibility in terms of combining the groups and having one presentation to everybody. So that's been a really good piece for a county that's as big as ours, you know, 54 cities and towns, 1.8 million people, and 877 square miles. So for people not to be reinventing the wheel and being able to share information, I think is a really great thing. And that's why we leave time after our presenters at every meeting for people to talk about what they're doing or what they might want to bring to people. So we will begin our speakers with John Kelly, who's the Director of Communications at NIT at Pride Star Trinity EMS. And that from the beginning, bringing in what was then separately Pride Star and Trinity, the ambulance companies that serve the Merrimack Valley, gave us a really great opportunity to kind of be on the ground knowing what was going on. And John and his coworkers provide 911 coverage for 13 communities in 2 states, both Massachusetts and New Hampshire. And, you know, I don't have to remind people, having seen what happened in that domestic situation this week, where 2 officers and one of the EMTs suffered fatal gunshot wounds when they responded to a domestic situation. It's a hard job. And like many of us in our work, they're seeing people it may be one of the lowest points in their life, whatever has happened. And John leads the only ACE accredited dispatch center in Massachusetts, as well as Trinity EMS's data assistance efforts. And this data that they're collecting is used both by public health and public safety. And he also helps other EMS and public health agencies across the county to implement EMS data assisted programs. John has really brought us, and you'll see when he does this presentation, so much great information, helping us to know, for instance, what day of the week do we have more incidents? What time of the year? What time of the day? Things that make our prevention efforts so much more targeted. So John is really one of the founding members of this task force and has been so good to us. And I'm really happy to welcome him back again this morning. John?
Thank you so much. I appreciate the kind words. Can we see that presentation?
Yep.
Oh, hold on. What happened? Sorry. All right. We can see the opening slide. Perfect. Thank you. Oh, hold on. It's not working. All right. So you can see this 624. My computer's all kind of messed up. I want to make sure you can see the first slide where it says 624. All right. Thank you so much. So last year in Lowell, we had 624 opiate-related 911 calls, which is a slight increase from the year before for us. And then what we're showing on this slide is the overdoses that were by Middlesex County residents. So those 624 instances, 481 were documented to have been Middlesex County residents. So we took care of 17 Billerica people that had an opiate-related call in Lowell, and we don't provide any service in Billerica, right? So those are patients from Billerica that came here. Marlboro there were 4 instances of a Marlboro resident coming up to Lowell and having some sort of opiate-related problem. So a subset of the information. So last year we had 432 documented instances where a patient took an opioid, went into respiratory arrest, Narcan was given, and a life was saved. So 432 times last year we have document for that. And of those 343 instances, those were Middlesex County residents, right? So on that little chart, you see Lowell, Chelmsford, Dracut, we're the ambulance provider for, so you think we'd see a lot of those patients. But again, we don't do any calls in Tewksbury, but yet 8 times last year, a Tewksbury resident was with one of my coworkers in an ambulance, 1 or 2, 3 minutes from death because of an opioid. And this is the information we're going to kind of talk about today. So every interaction we have with the patient, we create a patient care report. Our data set right now is about 15,000 patient care reports, and there's about 900,000 fields in it, anywhere from the age of the patient down to a 500 or 600 word narrative that the paramedic wrote, and we can mine that for all the information we receive. And there's really nothing special about what we do. Every ambulance service, whether you're Billerica's police ambulance or Westford's fire or a community that has a private ambulance service, we all have the same federal requirement, and that's called NEMSIS. I think the thing we do a little bit different is what do you do with the information after you've received it? So just kind of quick disclaimer, these are non-fatal 911 calls, right? So we don't do a very good job documenting fatals because we don't want to get into why someone dies. So anytime we stumble upon a fatal overdose, we just take it out of our data set. We don't want to confuse numbers. And while I'm presenting a lot of information from Lowell, I don't work for the city of Lowell. I don't speak for them. And we're going to talk about First Watch too, and I don't work for them. There's no financial tie-in between us and them. So kind of recover. So going over last year, so we have the 624 overdoses in Lowell. You could see month by month, right? As the DA said, we have real variations in when they're happening. So we had almost double the overdoses in November versus January. And a lot of that comes down to is the mix, right? What the potency of the drugs that people are receiving. So again, of those, we had 432 instances that a patient was moments from death. Again, January to November, quite a disparity in the quantity of the overdoses we're seeing. So one other thing we found in our data, so 10% of the time, coke or cocaine is mentioned in the narrative for our opiate patients. So pre-2018, in all those calls from 11 to 18 in our data set, we didn't have a single case that coke or cocaine was mentioned. Now it shows up about 10% of the time. So it begs the question, how many patients are overdosing? And ultimately, some of them are dying, taking a drug they didn't even know they were taking. Those 432 instances came from 46 different communities, mostly around the Merrimack Valley, but from other states as well. And we had 325 people. So just in Lowell last year, nearly one person, a different person every day was just moments from death. Some patients, we had one patient who was saved 12 times, but I mean, that's a pretty big number of different people that were so close to death. So we're going to step back a little bit. We want to talk kind of trends, right? So what's unique in Lowell probably isn't unique as far as the volume goes. So that's why we kind of present it this way. So that's the journey that we talked about way back in 2012, starting the opioid task force. So in 2011, we had 190 overdoses in Lowell, went up to 811. And you can kind of see that journey from, 2014 is really when we think fentanyl showed up, the rate. About halfway through 2014, it really doubled, and it stayed since then. So this is a subset of that last information, right? So we have the same time period, 155 months. We have 3,700 plus instances where a patient was in respiratory arrest in Lowell because of an opioid. Now you can see a low down to 43. Back then, we didn't have Narcan on the ambulances. That was just a paramedic drug. So we used to, as a BLS provider, you just ventilate and wait for the medics to show up. One of the concerning things we saw in the data is last year, we had a 22% increase in the number of patients that we found to be in respiratory arrest because of an opioid. And one of the part of the data we found is, so in 2017, only 60% of the time that we had documented for an opioid that Narcan was needed. Last year, that jumped up to 70%, right? So the concern is, will that continue to either increase or stay that way? We may hit kind of new highs for the number of lives saved. So, all right, so we're going to step kind of further back too right now. So that's the service area we provide. So now we're talking that same 2011 to 2023 period, but it's all 13 of those communities. So we have documented over 6,300 instances where a patient was in respiratory arrest because of an opioid. We have 4,350 different unique people that have been with one of my coworkers in one of our ambulances, either in respiratory arrest or just recovering from that in that 12-year period. 4,350 plus different people. We have documented 1,950 different Middlesex County residents. So again, in that 12-year span, nearly 2,000 different Middlesex County residents were in respiratory arrest in just our little corner of Massachusetts. So we're going to show the next couple slides. We're going to show, there's a rhythm to calls for us, right? So at 5 in the morning, we start to have lots of falls. Between 5 and 7, we do a lot of falls, right? From 7 to 9, we do motor vehicle accidents. Then they slow down. We do motor vehicle accidents from noon to 1 when people get lunch. So what we're showing here is that 12-year period of when the overdoses were happening, right? So you got by day, by hour. So you can tell, that call out there Monday at 3 in the morning, we've only done 7 overdoses in 12 years. So we don't do a lot of overdoses in the middle of the night or the early in the morning. And you can kind of see throughout the day, it gets worse and worse. And then from, noon to 10 p.m. is really when we have that most. And again, Thursday, Friday, Saturday, we have a disproportional number of overdoses as well. So now this is the month by month, right? So this is a pretty big data set, right? It's 15,000 calls. So it's a pretty big set. So we have, you can see that there's a lot more overdoses in September than really any other month. We did a study a couple of years ago where when you looked at June, July, and August, right, 120 days around that period of time. So that's about a third of the year. 50% of all overdoses happened in just that 120 days, right? So if you're either an outreach worker or you're an outreach leader and you're trying to figure out where do you spend your dollars, right? If you think about it, the summer nights, Thursday, Friday, Saturday is really when people are at the most risk of overdosing. So if you've got a limited budget or limited hours, that would be probably more an effective use of everybody's time. So, as we start to transition the presentation into the last kind of idea we have. So in that 12-year span, we had 129 days that at least 5 people died and were brought back with Narcan. So 129 days that 5 people, we're a relatively small player in the EMS world when you think about Massachusetts as a whole. We had one date in December 22nd, 2019, we had 9 different people nearly die in our ambulances from an opioid. And why do we have 9 some days and none the next, right? And it comes down to the mix. So let's think about Pepsi for a minute, right? So if you buy a Pepsi in Lowell, Massachusetts, Lowell, Florida, Lower Idaho, right? It's all the same, right? They have quality assurance, how much sugar and calorie, fat, and everything else, right? It's always going to be that same experience. Like it or not, it's going to be that same experience. But for our patients that inject drugs or use drugs, the amount of drug you buy from a dealer today, you could buy that same amount of the same drug tomorrow and it will kill you, right? Because there's no quality assurance, there's no quality control. It can be all over the place. And that's really what leads to a lot of people overdosing and dying. So on top of that, we have people dying and overdosing of drugs they don't know they're taking, right? Cocaine, right? Do they know they're taking fentanyl, marijuana? You know, personally, I went to a call. We had 4 20-year-olds overdose on fentanyl because they bought some marijuana from a street dealer, and it was laced, whether it was intentional or not. It had some fentanyl in it, and two of the patients overdosed. So, you know, we have people dying of drugs that they don't even realize they're taking. So we saw this article in the Globe, and I'm guessing most people on the call kind of seen it, right? And it's a struggle for everybody. How do we spend? There's an enormous amount of money that we have and we're getting over the next few years. And there's a lot of great ideas, and I'm sure we're going to spend it wisely, and there's lots of different ways to do it. So we wanted to come up and present one path we think could be a good use of that. So it's really, it would be a harm reduction strategy, right? So you have to spend it in certain areas. And really what we're proposing is to bring basically live monitoring of overdoses as they happen in the county. So our idea would be to use a product called First Watch. We use it now. It does automatic mining of EMS data, whether it's a fire department or a private EMS service, and it looks for keywords. So it looks for opiate, opium, heroin, Narcan, and that sort of thing. And then basically it can send out alerts, emails, texts, and whatnot on all that sort of stuff. And you could do it in a 24 or 72-hour window, right? So I think back, so in the 90s, there was a day in Lowell, we had a couple giant fires, and we started to have overdoses going out Bridge Street in Lowell. So there was an overdose at 50 Bridge Street. 10 minutes later, there was one at 75, 100, 150. There must have been 15 overdoses right in a row, right out Bridge Street in Lowell. It got to the point where we started staging the ambulances at 700 Bridge Street, and then there would be an overdose at 800 Bridge Street, right? So that's kind of that same idea where as a bad batch, right, if that's what we're going to call it, goes down Route 3 or up Route 9 or however that would work, right? As we figure out patterns and stuff, you'd start to see them popping up all over Middlesex County. And again, our fire department friends and EMS, they really don't need to change anything, right? We're already collecting that information with Nemesis. And really, my thought would be the trigger or the First Watch would live with the Matrix people who are already doing kind of that data after the fact. I didn't ask them, so they may not appreciate being volunteered for it, but you know, to me, that's where it made some sense. So we already did a beta test on this, right? So back in 2017, we kind of first had this thought. And basically what we did was we used First Watch for this process. Pro EMS down in Cambridge uses this as well. So we got with the First Watch people and we had our PCRs kind of talk to each other. And this is an example. This wasn't overdoses. This is some other calls. But this is what it would kind of look like, right? So let's say there's suddenly a bunch of overdoses in Woburn, and then they're in Burlington, right? So you start to gauge what's happening, right? Your community might know about overdoses that happen where you are, but if it's over the city limits, you may not find out about them. So that's kind of the visualization. This is what it would kind of look like. One of the big concerns is HIPAA, right? Patients still have privacy rights. We have to be very concerned with that. There's a lot of tools within this for to deal with that. So there's geo shifting. So you can, instead of an overdose appearing on a map on 1 Smith Street, you know, it would appear on Centerville and Lowell, right? So you can't get any information about where the overdose was. You can do customized viewing. So let's say there's an overdose in Framingham. Maybe the Framingham outreach team would be able to see the entire patient care report, right? They could get the address, they could get the whole story. But people outside of Framingham, again, have no right to learn any of that information. They would get a geo-shifted. So they would know an event happens, but they wouldn't know much about it for that, you know, to protect that patient privacy. You know, there's some potential other benefits of the fire EMS services as well. Like we use that product for a bunch of other things to help monitor our EMS system. So there's some upside for them just beyond the opioids. So I'm going to take a deep breath. So that's really it for the presentation. That's my email. If anybody has any questions about anything, I'm happy to answer them here. But if later on you have any questions or follow-up or anything else you want, please reach out. We're happy to help and share our experiences in kind of any way we can.
Questions, comments?
John, I have a couple questions. This is Alice Casey. So thank you. That was very informative. Could you break down First Watch a little bit more in terms of what it does? You mentioned that it searches for certain words. Like, what is it actually searching?
Well, so that's user definable. So for opiates, right, we've come up with, so it's used nationally. So about 1 out of every 2 911 calls in America touches First Watch at some point. So it's a massive tool. So for opiates, for us, it looks for fentanyl, heroin, because sometimes we spell things wrong, Narcan, Narcane, because sometimes we'll put an E at the end, morphine, heroin, that sort of thing, right? So it's a machine, just it looks for those keywords. So we use it for other things within EMS. So let's say you wanted to check for ankle fractures, right? It could look for that too. So you define which words you want. So there's about, the last I looked, there were about 40 systems nationwide that use that opiate trigger to find the suspected opiate. So it's not 100%, right? It's about 80% accurate, because you'll get, if somebody wrote in the paragraph, like for some reason wrote, I hate heroin, right? The system would pick that up because it's looking for keywords. But again, it's very good information today versus great information 3 months from now.
So it's searching your reports. That's what
it's searching the EMS chart. So whether it would be a fire department chart or an EMS or a private EMS service, every time we do a call, we have to do a PCR. And whenever that PCR is saved, the First Watch trigger goes in and reads it.
Okay. Thank you.
Sure.
You mentioned recently for 20-year-olds overdosing. Do you have data on, or do you know sort of anecdotally about just how this is affecting the younger groups, teenagers, just in terms of overdoses generally? Have you seen any trends?
No, we have very few, thankfully, we have very, very few teenagers that are, that we have in our data set. If I stumble for a minute, I could probably pull it up off to the screen and tell you, but it's not a large percentage of our patients at all, thankfully.
Great. And then my last question, you mentioned there aren't not a lot of overdoses at 3 a.m. Is that because everybody else is sleeping? Like, why do you think that is?
Yeah, I think a lot of people are just sleeping, right? There's a rhythm to our EMS data. Like we start to have more domestics from 6 p.m. to 10 p.m. because that's when people get home from work, and we do more MBAs. We do more elderly people falling in the morning than in the afternoon because they're waking up, they get dizzy, maybe they whatever other medical problems. So there's definitely rhythms we see in all EMS data, and overdoses is just kind of falls into that as well.
Thank you.
Sure.
Carol.
Hi, thank you so much. This information is so valuable for us who work in prevention and public health. Most of us have surveys from youth, but we are always looking for ways to track what's going on in our communities for all ages, but most importantly, over 18 quantitative. So this is powerful. A couple of questions. So you said, and thank you, it's a federal requirement for all EMS did you say track the same intake for incidents or just participate in the Nemesis system? So like I live in one town, my grant is 4 towns. Are you saying that all EMS providers use the same federal reporting system?
Correct. So EMS nationwide is under the DOT, Department of Transportation, and NEMSIS is the requirement that all ambulance services in America, no matter where you are, doesn't matter who owns or operates you, we have the same reporting requirements. So the information that we reported from our ambulance is the exact same that Natick Fire would have to report, right? There's nothing unique. We're not collecting anything unique that isn't required for every other service in America to gather. I think the part that's different is we then do something else with it.
Great. So you said, I think, when you have a call, you come to my home, you ask questions, or you, because you're trained experts, fill out quickly certain criteria. If I'm having a heart attack, perhaps you see drug paraphernalia. Can you kind of explain that, how that works? Because you're saying you get all sorts of information, and here you are in an acute situation. I'm just astounded how you can gather all that.
So the Nemesis requirement, I'm trying to remember, there's like 300 or 400 fields that we're required to get on every single patient care report. Now, a lot of it's automated, right? So date, time, location, all that sort of information is automatically put into the patient care report. So the providers don't have to put that in. Everything else, some of it is subjective, right? So you kind of think that it was an overdose. Sometimes we find most of the patients tell us the truth, right? There's still somewhat of a barrier where they don't admit to law enforcement what happened, but they don't really have an upside of lying to us. So a lot of times, even to this day, like the doors will shut of the ambulance and then the real story will come out. But it's a tough question to ask, to answer, excuse me. I guess it's just, like I said, it's just experience after doing out so many patient care reports. You kind of, like, Nemesis kind of narrows your thoughts down to it. So you have to pick a chief complaint, your primary impression, like what you think it was, what you saw. And then that's the importance of reading, whether it's machine or actually reading the narrative, because there's a lot more, it's open text fields, right? Most of the fields are just, you have to pick one of 300 ICD-10 codes, right? Whereas the narrative is an open text field. So we internally, we read every single one of those. So I have someone in my office who's read all 15,000 of those patient care reports for us.
This is awesome. And my last thing is, because I worked in addictions counseling, and I've had families or people say, we went to X hospital and my loved one fell down in the shower and were bleeding, but they were coded through the code of, say, an accident or a fall, but their substance is a secondary thing that's not captured. And I feel like the more we in prevention and public health can understand these systems, we can ask you all for the data and be able to have a snapshot of what's going on in our communities.
Sure. Absolutely. Yeah. And we also know where the patient fell, right? The ER is going to have, maybe they have the patient's, well, they'll have the patient's home address, but if they fell or overdosed somewhere else, they would not have that. And they wouldn't necessarily know when either.
And this is information that you said could be de-identified for us in public health to just understand incidents and trends.
Absolutely. So like in Lowell, for our first watch, so members of the co-op clients, right, they've signed a release that says, I'm willing to share my information. So what we're able to do versus the first watch trigger, the members for the Lowell co-op team, the Lowell Health Department, they can see those full patient care reports because that patient has allowed us to share that. But if we have some random person who's not part of that, we can share elements of it with the health department, but we can't share the patient name. We can't share the address where it happened or anything like that. But we can tell them, hey, an overdose happened around Bridge Street in Lowell at 2:00.
Right. Thank you so much.
Sure. And I saw someone ask about a veteran status. We do not ask veteran status at the time of intake.
Anybody else? Questions, comments? John, would you, I just want to raise one other thing with our group. Would you tell them briefly just what we were talking about before we began about the Mass Health?
Sure. So we were in a meeting last week with Tufts Medical School of Medicine, and we were doing a P2P program, if anybody's familiar with that. Anyways, so one of the presenters was up talking about there's a large reconciliation going on with Mass Health, right? So they're going through the records, and a lot of patients are losing Mass Health, whether they didn't fill out the forms properly or their income has got to the point where they have to go through the healthcare exchange. What they're finding is a lot of patients are losing their access to free buprenorphine, right? So if you're familiar with that, right, it's a medication that can help you control your addiction. Basically summarizing. So on Mass Health, you get it free, right? Because there's really no copay. But when you're in the exchange, they're finding a lot of patients are now suddenly have to come up with $600 a month to pay for that medication. So the thought was like, okay, well, how do we help support those patients? And I know the DA had brought some legislation forward years ago to try to get, Narcan, right? $40 or $50 copay for Narcan can be a barrier. So could we do the same thing with buprenorphine? Because again, these patients are in recovery. They're going in the right direction. And now all of a sudden they have a surprise $600 a month bill that's probably not going to help them.
So the reason I asked John to bring this up is in a really serendipitous situation. as many of you know, we've been pushing that bill for a long time to have a very modest, literally a penny per transaction tax on people who manufacture, bring, import, or sell opioids in the Commonwealth. This year, because of some of the changing medication, when we refiled the bill, we changed the language to not just say Narcan. We changed it to say any FDA-approved drug that is helpful in the treatment of substance use. So that would cover the buprenorphine. And that is why you may not have been anxious to support the bill because you think you're all set with Narcan or whatever, but we are really looking to get this bill over the finish line. So this is another reason, and we really ask you to think about coming together, calling your local representatives to try to push this bill, because if we get this bill through, it will solve that problem as well as the Narcan problem. And I'm going to ask Alice if she'll put the bill in the chat, and you'll see the number. So, and remember, the magic number for what representatives will tell you is getting 6 phone calls, emails, whatever on a bill is something that really causes them to focus on that, you know, because they are legitimately dealing with thousands of pieces of legislation. But if they see 6 or more people talking to them about something, they're going to go take a harder look at that. So this is just really a very fortunate turn of events that we modified that bill, and then John brought this problem up today that could be solved. And this bill is already pretty far down the road. So it's just a question of getting this bill to the finish line. So we'll put that in there and would be grateful if you were supportive of that. All right, anybody else for John? All right, John, thank you. Thank you for everything for many, many years. All right, turning to our next presenter, Pauline Hogler is a registered nurse and a certified professional dog trainer. She is the founder and executive director of Golden Opportunities for Independence. Her work is really dedicated to helping those who have a disability live a more independent life with the assistance of a mentor and a dog. And as you all know, we are big supporters of that here with we are happy to be one of the offices that now has a support dog in the office. So Pauline, we're happy to have you and look forward to hearing from you this morning. Thank you.
Thank you very much for having me. It's a real honor to be able to present at this meeting. We have a lot going on with our program. First and foremost, we're a service dog program where we breed, raise, and train golden retrievers to help people with a disability. The outcome of what our program has really segued into is a lot of mental health problems. And so we're seeing not only people applying for service dogs, but the benefit of dogs within either a police department or a facility, a school, any of those areas. The data out there and available on the benefits of the dog to be able to change environments, make mental health complications de-escalate a lot better than your typical things. And John, my goal is to prevent people from having to call that ambulance and do more preventative. So whenever I hear, and literally last week, Quinsigamond Community College got one of our dogs. He said that he had showed up at work. There was a fire truck on scene, an ambulance on scene. He walked up with the dog and they said they're getting nowhere. This girl's having a fit and a real mental health crisis. He said, if you want, I'll give it a try. And they said, you try whatever you want. So he walked up and 5 minutes later gave the guys the thumbs up and told them to go home. So as opposed to transporting that person to an emergency department, the time consumption of your guys, the time consumption of the fire department, but then as an ER nurse, the time consumption in the emergency department. So as much as you can say it's just a dog, it's so much deeper and so much more important for these dogs to be out there. So the real program that I want to introduce to you all is a Retrieve a New Start program that we're working with police departments. So police departments will purchase a dog from us and utilize them in any kind of de-escalating situations that they can. And a lot of school resource officers have them, so they'll bring them into schools and help. Brockton has one. It's not really helping there too much, but hopefully they'll get things under under wraps there. But all in all, having these dogs within the police department provides a bridge, a segue into kids, people who are suffering from substance use disorder, et cetera, which is a big problem currently. So our Retrieve a New Start program, we're trying to provide people who are in remission, in sober homes, a segue to benefit how they are healing. And so I feel it's much more than just the comfort of the dog. It's very important to have a stable housing environment. So we're working with Power Forward, who new NHL hockey star Kevin Stevens has developed, because he went through a real tragic accident on the ice where he pretty much did severe damage to his face, ended up in the hospital, and then ended up addicted to opioids. And so from his story, they now provide, he felt the biggest, the toughest part was after you go through that program and you say to yourself, I'm ready to go, I'm ready to do this, but then you get turned out on the street and you don't have any resources. You've got no one to turn to other than the other people that would trigger you to want to drink, whether it's, you know, they're not providing you with a stable environment or your friends who are doing it. And so they are providing scholarships for people to afford housing into sober homes. And they are selecting sober homes based upon an A+ criteria. They have to be testing and checking individuals to make sure that they're staying clean. The individuals in the house have to have a checklist of things that they have to accomplish, so they're being held accountable. They are required to have a they have to be back at the house by 10 o'clock. There's no overnights. There's, you know, they really I don't want to say tough per se, because that could be stressful, but they really are providing a methodology that will lead to success for these people. And so working with the police departments, we've developed a program that we're going to teach people how to train a dog. The biggest thing in our community resource dog program with the police departments, my belief is that it's about the human, it's not about the dog. You can put the most perfect dog into a really bad situation and you're going to see bad behaviors. You can put the worst dog into a really good situation and see really good things come from that dog. So having the support to the police officers during this time frame of raising this dog into a fully grown dog and get them through the difficult times is my priority. But through that, I learned that teaching these people how to train the dog actually developed more of a rapport. It made them feel more comfortable in communicating and developing rapports with other programs that are trying to help these people because it is inundating their every day. So Dr. Michael Hamrock, who's an addiction specialist out of St. Elizabeth's Hospital, felt, you know what, the number one comment I get from people is that we have a dog at home and it was the dog that was really able to get me out of that situation. I could tell him my story. The dog laid on my lap every day and it really made a difference in my recovery. So Power Forward has teamed up with Golden Opportunities for Independence and Power Forward, SANES, and Golden Opportunities for Independence. And through that, our teams of officers with dogs who are assisting their communities. And so we've started with Newton Police Department. We had Justin Lau participate in our education program for the people that Dr. Hamrock has been working with. And so our first pilot was last spring. We had 3 students. Dr. Hamrock came, he met with these students every day. They did typically their therapy with him. They would come to our class training with the officer who was teaching them skills. So it's almost as though it's a indirect approach to provide support for these people. people. As it turned out, one of our students was actually a thorn in Justin's side years prior. She had a lot of, she was from Newton. She had a lot of instances where she had called the police department and was a real time-consuming individual. And after we had this program, she hasn't called the police again. She has continued with our program to learn how to become a dog trainer. The feedback from the 3 individuals was over the charts. They really want to continue and get into our train the trainer. So we'll teach them how to become professional dog trainers. And so why do we want to do that? Why would I even think to do that? Partially because it's an industry that's growing leaps and bounds right now. So by doing this, we're giving them a skill. Our full program will cover from 0 to 2 years of a service dog. What we're finding with the sober homes is that when we put the dogs in their house, it's not just placing a comfort dog into the house. They're learning the skills as well on how to train this dog. They're benefiting from this dog going on and helping somebody else with a disability, and they're being held accountable for making that happen. And so through this program, we're really able to touch a lot of people. So we have also paired up with Kevin Cummings of the Felicia Rose Grant Program, who has offered to provide grants to police departments who want to sign on for this. So he's providing a $20,000 grant for departments that want to get these dogs into their department and follow through with this program and helping them provide stability for people with substance use disorder and prevention, hopefully preventing all of these calls that John gets. So I really feel it's in the pilot in the beginning stages, but what we've accomplished just within the past 6 to 8 months has been really profound. And so my ask for you guys is that you communicate with your local police departments and ask them if they would consider doing a resource dog from Golden Opportunities for Independence. The typical officer that does this is your community outreach officer, your school resource officer. Those are the 2 that really benefit the most. The department benefits the most from. So I'd say that's pretty much our program in a nutshell. Does anyone have questions for more details on any part of that?
Questions, comments?
Would you be willing to go to police, it's Cole from the Thorn Police Department, I'm sorry. Would you be willing to do like a presentation at a police department and talk to everyone in regards to this?
Yes, I would love to do that.
I will be in touch with you. Thank you so much.
Thank you.
This is exactly what this task force does best, is connecting people for those kinds of things.
That's wonderful.
And, you know, think about it. I really can't say enough about what the dog has meant for us, both in terms of our office and being out in the community. And this is an opportunity to sort of give at both ends. Carol.
Thank you. And I was looking at your website and your work is powerful. Just kind of a different question. Do you ever look for volunteers? We're close by to you and we're dog lovers to help.
Oh, that's fantastic. We are always in need of volunteers. So our breeding program, our puppy sitter portion of that is, I want to say, the most rewarding thing I have seen between parents and kids. And so if you have like a 13 to 16-year-old kid and you come here and you hang with some puppies for a while, it opens up that communication. They start talking to you. It's the one thing that your kid's going to say, oh my God, can we go do this? Versus you need to do this now, and that kind of thing. So it really is, yes, we're always looking for volunteers.
Okay. That's awesome. For a lot of different ages, I expect. And yes.
Right.
So thank you. I've got your info. Thank you for sharing.
If you have a dog, Carol, you're going to have to bring it and show it at the meeting.
We do have a chocolate lab, and I know all the benefits, mental health across the lifespan. But I also saw your website, and I know these things can be really powerful for people for helping. So I'll be in touch.
Thank
Oh,
you.
I didn't know our bear is a friend of Murph's. I didn't know Murph was from you, so that's great.
Yes.
All
Yes.
right. Anybody else? Get everybody? Thank you so much.
Thank you.
All right. Now, having talked about puppies, I dare Professor Beletsky to challenge to top the puppy piece. We're really happy to have Professor Beletsky here with us, who is a professor of law and health sciences and the faculty director of the Action Lab at the Center for Health Policy and Law. And that's an interdisciplinary appointment between the School of Law and the Bouvet College of Health Sciences. His expertise is on the public health impact of laws and their enforcement, with a special focus on substance use and addiction, infectious disease control, occupational safety of first responders. We talked a little bit this morning about the loss of the first responders in that domestic violence call this week, and policing as a structural determinant of health. Professor Beletsky is a frequent media commentator on harm reduction approaches to the overdose crisis in North America and other issues at the intersection of public health and public safety. Those interests also define the project portfolio for the Action Lab, which he founded and directs at the School of Law. Prior to joining Northeastern, Professor Beletsky was a member of the faculty of the Division of Infectious Disease and Global Public Health at the University of California, San Diego School of Medicine. He retains an adjunct appointment there, particularly helpful in the middle of the winter to take a little trip to San Diego. He received his undergraduate training in geography at Vassar and Oxford University, a master's in public health from Brown, his law degree from Temple University School of Law, and postdoc training at the Yale University Center for Interdisciplinary Research on AIDS. He's a member of the New York Bar and the dad to 2 bandits. So we'll talk about that later. But we're very happy to have you here this morning. Thank you for joining us.
Thank you. I'm sorry that I did send a much shorter bio, and I'm sorry that you had to read through all of that. But I appreciate being here, and also think that it's a hard act to follow the puppies. I do have 2 human puppies of my own, but no canines at this point. Yeah, so thanks for inviting me to speak. I guess just a little bit about myself in academic jargon. I work at Northeastern. I have a kind of a strange combination of legal and public health background, and started working on the overdose crisis. Really, it coincided with the start of my career, so I've been at it for about 20 years, and the crisis has spiraled during that time. So I've really kind of been observing it and doing research and trying to get it under control. So it's been a bit of a slog, to be honest. But there have been some positive developments, and have, for example, worked a lot on naloxone access, drug treatment access, thinking about how to improve the interfacing of the criminal justice system and drug use. So, for instance, improving access to medications behind bars. So all of these issues are things that we've been working on, and I've seen some improvements. But of course, overall, the crisis has continued to worsen, and that's been a huge source of frustration. So I wanted to talk a little bit about some of the work that we do in Massachusetts and elsewhere, specifically looking at the interfacing of policing and opioid crisis response. So our kind of starting point, and this goes back maybe to the conversation that you had earlier, is that law enforcement, other first responders are on the front lines of the response to the crisis, and this has taken a toll. So we know, for example, that law enforcement and medical first responders and fire have higher than average elevated levels of stress, burnout, also things like intimate partner violence, suicidal ideation. And there are many drivers of this, but one of them is, being on the front lines of the crisis. And when we talk to those first responders, especially cops, something that they often talk about there's kind of two categories. One is challenges to occupational wellness. So things like burnout, stress, frustration, a sense of futility. The idea that you kind of help people and then they come back over and over again, and seeing people overdose over and over again, or having to arrest people over and over again. This is something that a lot of officers talk about, and it's really takes a toll. And on top of that, folks have concerns about not just their mental kind of burnout and stress, but also their physical health. So things like needle stick injuries, which are relatively common. I mean, they're rare, but they're much more common among police officers than other occupations. And the idea that with a needle stick injury, you might also acquire a bloodborne infection. Again, this is something that is the chances of that are relatively low, but it's a high point of stress for law enforcement. And then in addition to that, law enforcement oftentimes is not well informed about other occupational risks. Like, for example, in the old days, folks were concerned about getting HIV simply from touching people, which is not something that can happen. And more recently, the idea that you can overdose from fentanyl by touching it, which is also something that is not possible. But there's lots of, reports in the media and on social media about these occupational risks that are not well aligned with the science. And so we've devised a training program called SHIELD, which is designed to address occupational health and wellness among police. And we've been doing this program for a number of years, but more recently in Massachusetts with support from BSAS, from the Department of Public Health of the state. And this is something that the training program is something where we cover various issues, including, we kind of lead with occupational health and wellness, but we also then integrate kind of the good news into the training program, which is that there are opportunities to task shift and to get people help so that they don't end up, having to sort of come in front of the police officers over and over again. So just as an example, and this kind of leads into the discussion of substance use treatment, we show the evidence behind methadone treatment as a public safety improvement tool. So there's been lots of research done on methadone over the course of the last 3 or 4 decades, showing that when people are on stable medication regimen and they are doing well on substance use treatment, they end up having fewer instances of criminal legal system involvement. And in kind of everyday terms, it just, folks find stability and they no longer get involved in criminal activity, and they end up getting rearrested fewer times. And the framing for the training is that this is actually an occupational wellness benefit because, again, there's a lot of sense of futility, and the idea of these, frequent flyer folks being able to find stability and kind of regain control over their lives is something that resonates with officers, and also gets officers and leadership involved in thinking about, okay, how do we increase access to these resources, and not just methadone treatment, buprenorphine treatment, other recovery resources, harm reduction resources, kind of creating a common sense of common goals for the behavioral health workforce and for folks in the criminal justice system to say, okay, we're working towards a common goal here, and the increased accessibility of these resources will benefit, of course, the folks themselves who are affected by addiction. It'll benefit the communities and their families, but it also will have benefits for the first responder workforce because it'll decrease their sense of burnout, stress, and futility. And so this is, some of the kind of broad strokes description of the work that we are doing. The specific issue, there's been some recent changes on the federal level to methadone accessibility specifically that kind of tie into this area of work that we're doing, which is that methadone is actually very unique in the way that it's regulated. It's unlike any other drug. A lot of those regulations date back to the 70s and 80s. And folks have been calling for them to be changed because it's really hard to be on methadone for addiction treatment. You have to comply with, a lot of different red tape. And so there's been some relaxations of those rules that were based on COVID provisions that were temporary, and they're now being extended and maybe made permanent. And they relate to things like take-home doses, so being able to have access to take-home medication rather than having to come in every day, which is, a pretty heavy requirement to have to come in and do observed medication therapy every day. There are also additional relaxations having to do with start dosage. So again, there's a lot of regulations with how much methadone you can get in the beginning. So there's been some flexibility introduced into the system. And, frankly, a lot of public health folks and now increasing number of folks who work in the criminal justice system continue to say we need to bring, methadone regulations in line with the 21st century, and with the reality that, folks who are on methadone are much less likely to overdose. They're much more likely to kind of regain stability and, again, kind of regain control of their lives and be less likely to be engaged in to interface with the criminal legal system, which assists, everyone involved. So that's kind of broad strokes about what we do and how it fits into, the Commonwealth's response to the crisis. And, the website for the training that I described, I'll put in the chat. And there's, you know, under resources, there's a whole description of like the research that we've done over the years. And I'm happy to talk about that, as well as really anything else that, you know, we work on, a whole bunch of issues like Section 35, access to harm reduction resources. Yeah. Thank you.
But what was her name though?
Can we just mute? Can people just mute so we can get rid of that good thing? I was really struck said about the sort of sense of futility, because one of the things that we talked about before.
Marion, you're muted.
Okay, somebody keeps muting me. Okay. I was struck by what you were talking about, the futility, because before you came on, I think John was talking and showing in the slides the same person having been revived 12 times.
Yeah.
With Narcan. And what does that mean for people when you are responding over and over? And how do you feel? How do you judge your own work when that's happening?
Yeah. Yeah. I mean, we've done some research on that. Sorry to, I don't mean to interrupt you.
Oh, sorry.
We found that it does affect folks' mental wellness, and people get really frustrated and they feel like they're, you know, putting themselves on the line, and people who are affected by addiction are just not getting better. They're not taking responsibility. You know, a lot of language around responsibility, not taking responsibility for their actions. You know, of course, addiction is a recurring issue, and recovery takes many attempts. And so that's something that we do cover in the training. But I think what is really useful for folks who are first responders is knowing, okay, you know, here's something that I can do for that person that can help them get out of the cycle. And it may not work the first time, but, you know, increasing their toolkit is really important. Not just, it just is helpful for their kind of sense of positive impact and reducing that sense of burnout and futility.
Other questions, comments?
Do you think that the training is appropriate at all for child welfare workers, DCF workers who respond in the field? They certainly have a lot of clinical knowledge of substance use disorders, but just more like the mental health well-being of constant exposure to some pretty significant substance use.
Yeah, that's a great question. We haven't worked with folks in the child welfare system. We have started to expand this model to prosecutors and, you know, DA staff, probation, parole, community supervision, corrections. But yeah, no, that's a really important point. There's just so much. The systems are overwhelmed, and the folks who work in those systems are overwhelmed. And I think that that's something that we don't talk too much about. You know, there's a lot of conversations in certain, you know, sort of pockets of our society about the harms of the system. But there's not really, I think, appropriate attention to how burnt out and, you know, stressed out folks who work in this, you know, criminal justice system are. And of course, it does then kind of result in the sort of things that we see in terms of elevated levels of all the things that I described. Also, retention and recruitment is a big issue. And that's something that is worth thinking about as well.
Okay, thank you. It sounds like a wonderful program.
Anybody else? Thoughts, questions? Thank you. Thank you so much for joining us. I appreciate it.
Thanks
Thank
so
you.
much for the invitation.
Thank you. All right, and now we're going to turn to Joan Taglieri, the Senior Director of the Cambridge Health Alliance. Joan is joining us from the Cambridge to talk about the new Community Behavioral Health Center. And I had an opportunity to go out last week to see it. Just a beautiful, beautiful building, great setting. And, you know, one of the things that it really drove home to me as I was driving out there last week was we forget, and Professor Beletsky just mentioned it, you know, we forget in terms of like the heavy lift of getting to a methadone clinic every day. Just the toll that getting someplace can take, the cost of public transportation, if there is public transportation, do you have minutes on your phone to use while you're traveling? Do you have, you know, a few extra dollars, especially in the winter and you're waiting for public transportation to get a cup of coffee? Do you have 2 kids in a stroller that you're trying to bring with you? You know, we ask people to do a lot in handling their recovery, their mental health. We hope that the services are available, but then you also have to make the services accessible. And one of the things I love about the new site is how accessible it is to so many of our communities. So I was really happy to be there. It is just a beautiful place. And Joan, I'm happy to have you here to talk a little bit about that.
Thank you, District Attorney Ryan, for inviting me today and for coming to our open house. We were very excited to have you here. So community behavioral health centers, people may know that the state organized a 25 community behavioral health centers across Massachusetts with the goal of significantly increasing access to behavioral health services when people need it. And those behavioral health services include services for people in crisis, of psychiatric and/or substance use disorders, and urgent care services, as well as ongoing outpatient services. And so we were at CHA lucky enough to be designated for the 5 towns of Cambridge, Somerville, and Medford, Malden, and Everett. And we initially opened our first site January of last year in Cambridge on the grounds of Cambridge Hospital. And we had always, in this effort, known that we needed to be closer to our Medford, Malden, and Everett communities in order to really create the kind of access that I think District Attorney Ryan was talking about. And so we were able to open a second site on the grounds of Malden Care Center. We're at the 2nd floor, that's 195 Canal Street in Malden. And what we have there, a 7-day-a-week urgent behavioral health care center. It's open 8 to 8, Monday through Friday, and 9 to 5 on weekends, only closed on major holidays. And side by side to that urgent care center are a set of outpatient services for both kids and adults, and both for people with psychiatric and substance use disorders. So it's really a set of services to really try to address some immediate needs that people may have, as well as some of the ongoing needs for services. CBHCs are largely charged with, you know, significantly increasing access to services, including crisis services, which are available 24/7. And that's through our mobile crisis team, clinicians who respond to any, you know, safe place in the community 24/7, and to all, you know, to our 5 communities. So that's one part of the service. Another is just having a call center, which is available 24/7. to respond to any calls with directly people in crisis or people who are just looking for information about behavioral health services. So those two services are 24/7, and the call center, I always encourage people to use it as a provider, to use it to consult with a clinician. If you're working with someone that you're not quite sure what the best approach is, and the best direction for services, to give a call to that center to really consult and help determine what the need is and the best service that that there is to connect that person to. Crisis services, you may know, are now available to anyone, anytime, regardless of insurance. Used to be specifically available to only Mass Health members, but that's changed. So regardless of a person's insurance, regardless of where they live, crisis services are available to them. Our urgent care center at Malden, similar to the one that we have at Cambridge, anyone can walk in anytime in the hours of operation. And we found in Cambridge that was one of the most successful parts of establishing this service. So people don't need an appointment. They don't even need to call ahead. They can just simply walk in when they feel the need to have some help around a behavioral health issue, or if they think they need some help. I mean, what we do is to begin by just evaluating someone's need, understand it best we can, and we can initiate services immediately if needed, or we can at least get them connected to the right level of service that is needed as well. During the first couple of months of opera, we opened in Malden on December 18th, and we've served over 500 people with our urgent care center already. And again, most of these folks are coming in on their own, which is exactly, I think, what we want. But some people need some guidance and come in with a first responder, come in with a clinician or a caseworker. That's great for us because then we have the ability to talk to someone that has some knowledge of the person as well. And so we invite people to do that when that makes sense. We're seeing, again, kids and adults, so all ages are served here. So on staff at that urgent care access center are a multidisciplinary staff made up of clinicians who are competent in seeing kids and families, as well as clinicians for adult and elder adults, and competent to really help evaluate and treat people with addictions, again, as well as psychiatric issues. So that front door is clinicians, prescribers, psychiatrists, nurse practitioners, as well as recovery coaches, caseworkers, and peer specialists, so that we really can try to attend to the key issues that are bringing people to us. I'll just stop for a minute and see if you have any questions so far.
Questions, comments? Carol.
Thank you so much. Just to clarify, do the CBHCs bill if someone has private insurance, or is it a referral out for, say, if it's therapy? I know there's no cost for crisis, no matter what your insurance is, but any other service or group or even a clinical referral, how does it work if you have commercial insurance?
So that's a great question. So as you noted, if it's a crisis, anyone can use it regardless of insurance. For ongoing outpatient care, it's still insurance dependent. I wish it wasn't, because if we had a universal approach, you know, to all behavioral health services, that would be the ideal. But once the crisis has resolved, we're really needing to connect people with services that their insurance would cover. Now, most insurances cover outpatient services. It's the issue there is really finding an outpatient provider. It's still the case that since the pandemic, the need for behavioral health services has increased. It hasn't gone down that much. I think we're still seeing a high level of need. In the workforce is still not what it was before the pandemic. So it is still difficult often to find some ongoing care, outpatient type care, but that's one of our jobs, is to find the outpatient care, whether it's with us at CHA or with another provider. So evaluation, initial treatment if that's required, but also finding a place for people to receive that ongoing care. But yes, insurance kicks in when it comes to ongoing care.
Thank you.
Other questions, comments? Joan, thank you. Thank you. And thank you for the work you're doing over there. I mean, I think just seeing the place and being able, I think that, you know, it's always a little bit difficult for me to think about you're in a crisis and make an appointment 2 weeks from next Thursday. So the fact that you can walk in and get services is great. You know, just the setting itself, lots and lots of private treatment rooms as well as group rooms, really a place that I think people would be very happy to go and much needed in that community. So thank you.
I just have one thing, if I could. We have developed a lot of business cards, I call them, with all the information of where to call and where to go, that I have in 7 different languages. I'm happy to distribute those cards to anyone who thinks it would be helpful to their, you know, the people they work with. So if you just want to email me directly and let me know how much you need and in what languages, I'm happy to do that.
Will you just put your contact in the chat?
Sure, yes.
So people can do that. All right, thank you.
Thanks
Because we're
so much.
recording it as well, so people can see that later
Okay.
if they need it. All right, thank you to all of our presenters. Just really a lot of great information this morning on different topics. I want to turn it to our partners. Anybody have anything they want to tell the group about, thoughts, reflections, anything you want to invite people to or let people know about? No? All right, we're quiet. Quiet. I remind people we continue to have lots of Narcan, lots of fentanyl and xylazine test strips. I want to be pushing those out. So if you need those, just reach out to us. We are happy to give you whatever you want in terms of getting them out there to be used. So again, many thanks to our presenters. Keep in mind, you know, as you go about this work in the next couple of weeks, as challenging as it can always be, that seeing that 50% decline is really a very significant change. And it is really because of the work we've been doing here. So I'm very grateful. And we will see all of you next month. Thank you. Take care. Bye-bye.